Thank you, Dr. Chandrasekhar. I welcome you all for this important Journal Club meeting. I congratulate Dr. Kalaivani and her team for taking this topic. And I think this is a very important, nice Journal Club topic for any of the surgeons who open and close the abdomen. I'm sure there will be a lot of discussions, and also the fine analyzing the journal in this published in the British Journal of Surgery. I welcome you all and hand it over to Dr. Kalaivani. Please take over, Dr. Kalaivani.
Thank you, sir. Thank you for the opportunity, sir. So good evening, one and all. We will straight away, without wasting our time, we shall start with the Journal Club. Dr. Zaiba is a second year PG. She will be presenting. So in between, we will be stopping, asking for questions and for comments at most of the important steps. So we can give our analysis and let us have a fruitful discussion so that we understand, rather the postgraduates understand what is the importance of a Journal Club and how to read an article. So straight away, Zaiba, can you please start?
Good evening, respected teachers. I am Dr. Zaiba from second year postgraduate of Statistical Institute of Medical Science. First of all, I would like to thank all the members of all the Delhi Secretary and all the members of Karnataka State Association and my moderator, Dr. Kalaivani, for giving me this opportunity to present this journal club.
Zaiba, have you kept two systems open, your laptop and the phone? Just check. There is some echoing.
And her voice is not clear.
Yeah, voice is breaking.
Ma'am, now it's clear, ma'am.
Yeah, you speak, let's see.
Yes, ma'am.
Yeah, it's better. Yeah, I can start.
So
there is some echoing. No, all of us tested ourselves. Zaiba, you didn't test it. No, you are not audible.
hello, ma'am. Can you hear me?
Yeah, start presenting.
So the journal club which I am going to be presenting today is
Not very clear. Okay, you continue talking. Let's see.
not able to.
No, you are not audible in between. Slide share is there? You are only doing slide share, or you have given to Dr. Chandru?
No. She has the slides. We have made her co-host. She can share the slides.
Unfortunately, we are not hearing her very clearly.
You have done a trial run, Dr. Kalaivani?
No, sir, because we regularly do, so I just.
For all this trial run
Yes,
is a must.
yes. Hello, Zaiba, where are you?
I'm trying to.
Huh?
Yes.
Yeah. I'm really sorry about this, sir.
If you have slides, you can open now, share the screen.
No, we can, I don't have the slides, sir.
Anyone else? So that she can read and present.
Yeah.
I'm sorry for the. So the title of my study is the effect of the short switch technique.
Share your screen, Zaiba.
Yes.
Yeah, fine.
Yes.
Make it full screen now.
Full screen in it, yes.
Fine.
Okay. Okay.
So the title of my journal club is Effects of Short Stitch Technique for Midline Abdominal Closure on Incisional Hernia, a Randomized Control Trial. My hypothetical research question is it beneficial to utilize a short stitch method in comparison to a long stitch method for midline abdominal closure to reduce the risk of incisional hernia? Objectives of my study, is to evaluate the strengths and weaknesses of this study, the appropriateness of the study design, which was conducted, the statistical methods which were employed, the conclusions drawn, if we can extrapolate this technique, and if the main question is if we can motivate patients to use this technique.
Can we stop this at this point? We will just first show me the title once again, Zeba.
Yes, ma'am.
So what do you understand from this title?
From this article title, ma'am,
Yes.
it states that they are trying to compare a short stitch technique with for midline abdominal closure, ma'am. And the article which they are trying to employ, they are trying to do an RCT, which is a randomized control trial. And they're trying to see the effects of this technique in midline abdominal closure procedures.
So has it been explained in this title?
This title is explaining the what they are trying to portray, ma'am, and what kind of clinical trial they are employing.
Okay.
Define short stitch and long stitch, please.
She'll come in the introduction, sir. You're going to explain, right, Zeba?
Yes, ma'am.
Yes. Okay. Now please go ahead.
This is the hypothetical question, ma'am, which I've.
Don't keep saying ma'am in between. Just continue talking. Yeah.
The objectiveness of the article was to evaluate the strengths and weaknesses of the study, the appropriateness of study design, the statistical method employed, the conclusion which we are being drawn, and if we can extrapolate this technique, and if we can motivate the patients to use this technique. Article details. The author of this article was René N. Potley, Dorian N. Randi, Malte Schrin, and all. The study was conducted in LMU University Hospital, Department of General and Visceral and Transplantation Surgery, which was done in Germany. And the publisher of this article was Oxford University Press, which was done in the year of 2022 April. Conflict of interest, none were declared, and the impact factor of this article was 1.68.
Hello. I don't think there is a impact for article, impact factor for the article itself. It usually is an impact factor of the journal. So yeah, I think the British Journal of Surgery is somewhere in the range of 5.5 to 6, I think. Where do you get this figure of 1.38?
So the impact factor is an index which reflects the yearly mean number of citations.
From where did you get this impact factor is asking. This is British Journal of Surgery, right?
Yes, ma'am.
For that journal, what was the impact? Is this
impact factor for BJS is in the range of 5.5 to 6 or something like that. So 1.38 is a bit low.
Where did you get this information from is a question, Zeba.
Yes, ma'am. The article, it had correlating with the other two articles, sir. They have retrospectively done other two articles also, which was conducted in 2015 and 16.
No, Zeba, wait. Dr. Ravi's question is, you said the impact factor is 1.68. From where did you get this 1.68? Is what Dr. Ravi is asking. How did you get this?
From the publisher from the Oxford University Press.
You obtained it from the website, correctly?
Yes, ma'am. It's from the website.
Dr. Ravi?
I think BJS is, as Ramakrishna is pointing out, is 5.5. So it was ranging between 5.5 and 6 usually. So I think you don't calculate the impact factor of one article. It's usually the journal that you calculate the impact factor. Okay, carry on.
Go to the next slide, please.
I had a small doubt. Same Dr. Naz was also asking, are you motivating the doctors or motivating the patients in your objectives?
We should motivate the doctors, sir, per se, to use a short stitch technique. That is the objective of the article.
But your objective, the last objective says motivating patients.
We can also give the option to the patients, sir, if they would want to reduce their risk of incisional hernia, per se.
Fair, go ahead, fair.
So the introduction, the standard incision for a wide range of abdominal intervention is midline laparotomy. And in this study, we have considered an incision of more than 15 centimeters. According to a study which was conducted by Hoyle et al., he performed the laparotomy in 2,983 patients, where he concluded that the incidence of incisional hernia occurs in 10 to 69% of patients. This study was conducted in Germany and Austria, and to explain the magnitude of incisional hernia, Germany used to operate approximately 50,000 of incisional hernia.
Just go back a little bit. We are fine all this while. Just go back a little. Take your face away and now talk. Yeah, talk now.
To compare, the magnitude of incisional hernia in Germany and Austria was approximately 50,000. And coming to the healing of midline incision, the healing of midline incision is generally slow because of the presence of linea alba and the variation in the intra-abdominal pressures. And,
No, the audio is not clear, not able to follow anything, madam.
Is there anyone else using besides you?
No.
You're alone in the room. Okay, you present.
Zeba, go slowly, just relax and present. Okay.
It was fine all this while. Is there another presenter in the room? No. Okay. Present.
Mobile, you check your mobile whether it is on.
Is it on in mobile?
Put it off.
Okay.
The healing of midline incision is slow due to the character of linea alba and the various intra-abdominal pressures. It can further be compromised by clinical risk factors, which include obesity, male sex, chronic obstructive pulmonary disease, and perioperative chemotherapy. In this study, they have used a long-term absorbent suture materials, and they have claimed that it reduces the hernia rates in elective midline laparotomies. In this study, they have defined incisional hernia by considering the European Hernia Society, which states that abdominal wall gap with or without a bulge in the area of a postoperative scar is perceptible or palpable by clinical examination or imaging. The imaging which they have used in this study is ultrasonography of the abdomen, which they have performed at a 1-year follow-up period. The aim is not mentioned in this article. So, the aim which I have formulated in this study is to determine, to analyze, and to compare the results of a short stitch technique with a long stitch technique. And the material used in this study was monomax, which the chemical name is 44-hydroxybutyrate suture.
Why are you stopping? Yeah. Any comments? You have to tell, Zeba.
I would like the audience to comment on the title, introduction, and the
means your colleagues. You should ask your friends, PGs, other PGs.
Yes.
Anyone else? Yeah, you can call. Anyone is answering that?
Yes. I would like to ask Renisha ma'am to comment on the title of the study.
Renisha?
Yes, ma'am.
Yeah. Why all of you are echoing today? Comment on this.
Yes, ma'am. This study is a comparative study. So the title can be framed as a comparative study of short stitch technique versus long stitch technique for midline abdominal closure on incision hernia. It would be better, I feel.
I like some comments from the seniors, Dr. Lakshman, Dr. Ramakrishna. What explanation they have given, or is there anything that could have been better? Dr. Ravi?
No, I think it's okay, title, introduction, and aim. We don't have to stop here because there are a lot of other important things to discuss. So I think we should move on.
Okay, fine. Okay, just move on, sir.
So the materials and methods which were incorporated in this study. The study was a prospective, multi-center, parallel group, double-blinded, and a randomized controlled superiority trial. The cases which were operated were from March 2014 and December 2019, and they were randomized. A computer randomization was done, and a case analysis was conducted in 2020. Coming to parallel group, the study design in which each subject is randomized and it is compared with 1, 2, or more distinct based on the treatment and the intervention which was employed. And the superiority trial is when the aim of an RCT, that is a randomized control trial, is to show that treatment of one category is superior to another statistical test, and it is employed, and the trial, such trial is known as a superiority trial. Coming to the inclusion criteria, the patients with more than 18 years of age were included with ASA grade of 1 to 3. The cases which were scheduled for elective and primary midline laparotomy with an incision of more than 15 centimeter were included, and an expected survival time of more than 1 year for whom informed consent was obtained were all included in this study. The exclusion criteria of this study were patients who underwent emergency laparotomy were excluded. A pancreatic tumor patient which was diagnosed on basis of CT was excluded. A patient operated on owing for any abdominal aortic aneurysm was excluded. Patients who presented with peritonitis, any coagulopathy, patients who were on immunosuppressive therapy or chemotherapy within the last 2 weeks, and pregnant women and patient who had severe neurological and psychiatric diseases, and patients who had lack of compliance were excluded from the study.
Zeba, I'll stop you at this. You have not explained what do you mean by short stitch and long stitch and what suture material has been used. All that you have to explain.
Yes, ma'am.
That's a question from all the audience.
It's there in the coming slides.
Explain now. Shall we wait, Dr. Nas?
Proceed. Anyhow, you are getting in the next slide, no? Continue.
Yes. Continue.
The patients were divided based on the baseline demographic details so that they could exclude the confounding bias. So patients were divided into short stitch and long stitch. In short stitch, 2015 patients were included, and on long stitch, 2010 patients were included. To eliminate the confounding bias, they were equally divided into short stitch and long stitch, and they were divided on the basis of the female sex, BMI of more than 30. If the patient was a smoker or a non-smoker, any alcohol consumption based on the ASA grade, the type of surgery, and any comorbidities which were present in the patient. And so that the randomization, so that each and every patient gets an equal chance to participate in the short stitch as well as in the long stitch.
No, I think you have not understood that. You see, basically, they would have divided the two groups and they have shown that both groups are comparable. I don't think you can allocate patients. When you are randomizing, you can't allocate patients. But if you look at the demographics, they are similar with respect to the factors that you have enlisted. Okay, so you can't say that they have randomized based on these things. Did you follow what I am saying?
Yes.
See, basically, they have randomized using computer-generated randomization, and it is double-blinded both to the patient and to the surgeon. And then they have shown that the demographics show that both the groups are comparable. That is all it is. Okay.
All those factors which you read out are comparable for both the groups. Okay, that's the explanation you should give. Yeah, now you please talk about the type of stitches before you proceed, because everyone wants to know what it is.
Yes, sir. The patients were divided into long stitch and short stitch. 210 patients were in short stitch and 204 in long stitch. So in case of long stitch group, a 10 mm stitch interval was included with a 10 mm distance from the wound edge and a 150 centimeter of poly-4-hydroxybutyrate with a round body of 48 mm needle was used in a long stitch group. In case of a short stitch group, 5 mm stitch intervals bites were taken with a 5 to 8 mm distance from the wound edge and a 150 centimeter thread with a 26 mm round body needle was used.
Okay, now you go to that previous slide. Yeah. Explain.
Out of the 1,587 patients, 1,082 were excluded because 1,071 were not meeting the inclusion criteria. 11 were violation of intraoperative inclusion criteria because 11 of the patients would presented with peritonitis or coagulopathy or a pancreatic tumor or any patient which was owing to an abdominal aortic aneurysm. 425 patients were randomly assigned, and out of which 215 were allocated to short stitch, 210 were allocated to long stitch, and 215 received allocated intervention, out of which 16 re-laparotomies were done within 1 year, 3 were due to burst abdomen, and 5 died within 1 year, and 9 withdraw the consent to perform in the study. In the long stitch group, 210 received the allocated intervention, in which 28 re-laparotomies were done within 1 year, 10 due to burst abdomen, 10 patients died within 1 year, and 3 withdrawn their consent to participate in the study. Out of the 215 patients, 5 patients were lost to follow-up. So 210 were included in the primary outcome analysis in the short stitch technique, and 204 in the long stitch technique, where 6 patients lost to follow-up.
Just a moment, Zepa. There are some questions in the chat box regarding this. Now, one is 3 patients had aortic aneurysm, which is actually an inclusion criteria. And why have they used that? Is the question. Aortic aneurysm was an exclusion criteria.
Yes.
That is what the author has mentioned.
Yes.
But when it comes to comparing the groups, even this was compared, it says aortic aneurysm.
Yes, ma'am.
Baseline demographic and clinical characteristics, under that comorbidities, aortic aneurysm is included. So was that included in the study?
It was not included in the study, ma'am.
No.
All those 3
But
patients.
there are 3 patients.
No, Zaiba, I think you have not understood. Zaiba.
Yes, ma'am.
See, it is the abdominal aortic aneurysm was an incidental finding. They were not operating for abdominal aortic aneurysm. So that is why these patients have been included. You understand, no?
Yes,
see,
sir.
When you opened, you found aneurysm, but you are not actually operating for an aneurysm. You are operating for something else.
Only the patients which were
so these three, these 3 patients, comorbidities, 2 patients in the short stitch group and 1 patient in the long stitch group. When you opened, they found that they had aneurysm, but they are not operating for aortic aneurysm. They were operating for maybe colon cancer or something else. So they are comorbidities. That's all. It is not. They have excluded patients on whom they were operating for aortic aneurysm. Did you get that?
Yes.
See, the exclusion criteria means anybody being operated on for aortic aneurysms are excluded from the study. But these aortic aneurysms are just comorbidities. They are incidental findings on which you are not actually operating. Okay? Just like diabetes, for example, or hypertension. Is that clear?
Did you understand, Zeba? Please say yes or no.
Yes, sir.
Okay, carry on.
The next question is how the distance of 5 millimeter or 10 millimeter decided. Was there any measurement carried out?
Yes, the there was a operator or a nurse which was after the surgeons which were trained by a principal investigator, and the surgeons were trained using a training videos, and the number of throws and the stitches which were taken at regular intervals, a study nurse or any other assistant counted the number of stitches intraoperatively, and digital timers were used to measure the suturing time, and all these parameters were assessed objectively.
Okay, proceed. You have not explained exactly. Okay, please proceed. This is not mentioned anywhere. This is to the answer to the question. Please continue.
As in the materials and method, the surgeons were trained on site by the principal investigator using training videos. The number of throws were not defined, but at least 6 throws for the long stitch technique and a self-fixing knot for the short stitch technique was performed in all the intra-abdominal operations which were performed. And all the following parameters were recorded and measured in both the treatment groups. One was the length of the wound, which was 15 centimeter. The number of threads used comparatively in the short stitch and the long stitch, the length of the remaining suture material which was left, the number of applied stitches, and duration of abdominal wall closure. All these 5 were objectively assessed by a study nurse or any assistant who counted the number of stitches. Statistical analysis were done using a SAS software version of 9.4. And
Zaiba, what is the last, go to the last slide. Last slide. Not this, the consort diagram.
Previous one,
this one. So what is the purpose of consort diagram? Where do you see them used very commonly? This is called a consort diagram. So usually it is seen in which particular studies. It should be there in every study, but especially after.
Especially it is generally used in a case of randomized controlled trials.
Yeah.
So that we give opportunity for every patient to participate equally in both the groups.
No. That is not the purpose of the consort diagram. The consort diagram gives you a stepwise, detail of the study and the exclusion, how many patients were excluded, have they given the reason for exclusion. So this actually gives you whether the RCT was conducted, properly according to the guidelines, what is usually called the PRISMA guidelines. Have they conducted the study according to the guidelines? So if this consort diagram is not there, then you have to question the veracity of the study, because sometimes they can conveniently, exclude patients who are, probably causing the study to go one way or the other. So they have to give you explanation as to why they excluded these patients and what happened to them. Have they included them in the analysis? All these things will be, the details will be given in the consort diagram. So that is why it is important to go through that.
Okay, sir.
Okay. Ramakrishna says to make sure all patients are taken into consideration for the analysis. Okay, that's all it is. Okay, carry on.
It's nothing but consolidated standards of reporting trials. Okay. Proceed now.
Endpoints were presented as frequencies and weights, and 90% of confidence interval were given by appropriate. The satisfied test was used for rate comparison, and a p-value of less than 0.05 was considered statistically significant. I would like to ask the audience for critique for the materials and methods of the study.
Any questions from the audience? The materials and methods, please.
Can you hear me?
There's a question for you. Can you hear? Hello, Zaba, can you hear?
Yes, ma'am.
There's a question for you from Dr. Shivram.
No, it's question for others also. This is a study which has been sponsored by the manufacturers of the suture.
Yes.
Will it weaken the study or it will have any effect?
So because of the funding of the suture material, sir, it generally weakens the study because it can result in bias in portraying that the suture material used was a good suture material.
Ramakrishna, will it weaken the study? Ravi Shankar?
I see if they have used the same suture material for both arms, then it won't. If it is used for one arm and another suture material used for the other arm, then obviously it will bias the study.
Hello.
Yes,
Hello.
Hello.
Please go on.
Venkat here.
Yes, Venkat, please go ahead.
No, how can we say that if the company is sponsoring a trial, it will be biased? Because it will be a double-blind study or a controlled study where observations are documented by somebody else, tabulation is done by somebody else. Then it will be a controlled trial study, right?
No, that is what I said, Venkat. I said, if, for example, only one suture material was being sponsored by used and that showed, the study showed that suture material to be superior, then you can probably question the veracity. Otherwise, I don't think it is a factor.
If you really do a strong study, want to know the exact results, then the study will be well controlled and done by reputed investigators. It will not be a biased study.
If
it is a biased study, then it has to be disproved in some other study. It can be disproved.
Here they are comparing short cyst, long cyst, and not the suture materials. No?
Yeah.
Correct.
Yes, same suture material is being used for.
Whatever the suture material they use, they are comparing the long and short stitch. Whatever the suture material.
Otherwise, if they are comparing the one suture with another, or one chemotherapy drug with another, there is little scope for any manipulations.
Yes, that's exactly what Dr. Ravi also is telling. You have any comments, Zeba, on that?
Similar suture material was used, ma'am, in both the short stitch as well as long stitch, which was monomax, ma'am, poly-4-hydroxybutyrate sutures. Only the suture technique which differed in both the studies.
And also the size of the suture material was different.
Also the size. In case of long stitch, 10 mm suture stitch was used, and in case of short stitch, 5 to 8 bites were taken.
The suture size also was different. The suture size was number 1 in case of long stitch and 20 in case of short stitch. And the diameter of the needle was different. This was the only difference, though the suture material was same. Any comments from anyone else?
Ramakrishna?
Good evening, sir. I agree with Dr. Ravi Shankar. If you are comparing one suture material with the suture material of another company, then the bias may be there because the integrity may be questionable and it is left to the audience how to decide it. Only thing we have to present it. The other thing what I wanted to tell is they have changed in the methodology she didn't mention, they have changed the protocol in between. Actually, once you start the study, you should not change the protocol till the end of the study. If it is done, it is a defect or weakness of the study. That is one. Secondly, they have taken stitch trial where they mentioned the weakness of that trial was they have calculated, they have followed up the patient for 1 year and they have given hernia rate. And they say more than 50% of the incisional hernia they develop after 1 year. And in this study also, again, they have employed 1 year only. So once they have seen this as a weakness, they should have improvised it and they should have gone for a longer follow-up period. They have again taken for 1 year only. And you have only 50% of the hernia. God knows how many will develop in next few years. That is another problem. And in the statistical analysis, they said the sample size calculation. Usually, when we have a similar study published before, we took those numbers into consideration to calculate the sample size. There, they have taken one study which has given a large difference in the incidence of the effect. Effect size means now in this case, effect is the incisional hernia. What is the rate of incisional hernia in one group? What is the rate of incisional hernia in the other group? The difference between these two will affect the sample size. That is very most important criteria as when we are doing this randomized control trial. They have taken it where the defect size was difference between the effect size was very huge in that. And then when they started this study, the actual incidence was very small. So for this sample size, the power of the study becomes very, very low. And there is every chance that they have reported a negative effect, false negative conclusion. Chances are very high in this study because this sample size is totally insufficient for the incidence of incisional hernia, what they got, and the difference between the two groups. That is a very strong weakness in this study.
She'll be coming to those strengths and weaknesses, sir. This is only on the methods and methodology. Was there any fault? Okay, thanks, sir. Thank you, sir. Thank you for your input. Shall we proceed? Yes. Zeba, go to the next slide.
Yes. So the critique of the materials and methods were there was computerized randomization done. Double blinding was performed. It was a prospective study. A standardized surgical technique was performed in both the groups. Good follow-up of 1 year was done. Like the patients were followed up for a period of 30 days, 60 days, and for 1 year, and appropriate statistical tools were used. Against the materials and methods, my critique would be the surgeon's expertise was not mentioned in the article, and the number of throws which were taken were not defined.
Any other comments apart from this? Dr. Ramakrishna has already given a brief on all the critics.
And another problem is there were 106 surgeons for doing 425 cases. That means each surgeon has done only 4 cases. So if it is a new technique, there will be a lot of learning curve. So whatever you teach initial period, they will have problems. And a new surgeon come again, you have to teach him. Like that, they have used 105 surgeons for this study. It is not a good thing, madam. It is the results could be skewed in these cases.
This is what we should critically analyze. Dr. Ramakrishna is giving you a key point. This is how we should look into an article. These are the points so that whether the study can be used or whether you can use it on your patient or you can extend it to the different set of population. So this is an important critique. I hope all the postgraduates and everyone understand this. Okay, proceed, Zeba. The next.
The results of the study were divided into a primary outcome and a secondary outcome. The primary outcome was mainly to know the rate of the incisional hernia, which was followed up for a period of 12 months, plus or minus 1 month. And the secondary outcome, which were assessed, were depending on the quality of the life, which included any surgical site infection, burst abdomen, wound healing disorders, any seroma formation, hematoma, or anastomotic leak. The primary outcome of the study stated that in case of a short stage group, out of the 210 patients, 7 patients developed incisional hernia. And in case of the long stage group, out of the 204 patients, 13 patients, which accounted for 6.4% of patients, developed incisional hernia, with a p-value of less than 0.156, which was not statistically significant. A combined endpoint of incisional hernia as well as burst abdomen was considered, in which short stage group, 10 people out of the 210 patients developed incisional hernia, and 23 patients of the 204 patients developed incisional hernia in the long stage group, which stated that the p-value was 0.018, which was statistically significant.
Have they accounted for all the burst abdomens? Have they taken that into consideration in terms of reoperations? And then have these patients had any other problems and all these things? They have not seemed to have given much information about the burst abdomen cases.
No, sir, they have not considered pre-operatively any burst abdomen cases.
Not pre-operatively.
Not pre-operatively.
How can you have pre-operative?
Post-operatively,
Post-operatively.
post-operatively, they have not considered, sir. But as a case of in the end, as multiple logistic regression models was considered, sir, and to know the primary outcome, that time they considered incisional hernia as well as burst abdomen together, because they considered burst abdomen as a risk factor for the development of incisional hernia.
Yeah, Dr. Ravi, was that clear or?
No, I think, see, burst abdomen itself is a primary failure of your suturing technique, isn't it?
Exactly. So the previous slide you showed, Zeba, Dr. Ravi.
Whether it is due to the patient factor.
It may not be the failure of the technique, it may be due to the underlying cause also you have to see for
but it is a confounding factor, right? That's what I meant. It could be due to patient's general
technique
condition,
or underlying severe condition.
Yeah, severe condition or whatever. So there are lots. It can be a confounding factor. So that they have not accounted for it at all. That is my question. That's all.
Have they included, Zeba, have they included the burst abdomen cases as incisional hernias at the end of the study, or have they excluded them?
They have included, ma'am, because burst abdomen may itself anticipate incisional hernia, and a high rate of burst abdomen can bias the results for incisional hernia. So they have
included in the results.
They have given two endpoints, ma'am. One endpoint is just incisional hernia, and another was combined with incisional hernia and burst abdomen, because they were anticipating burst abdomen to be a cause for development of incisional hernia in the future.
Shall we proceed or any other?
No, proceed.
Yeah, Zeba, continue.
Secondary outcomes which were assessed were surgical site infection, hematoma, seroma, anastomotic leak, ruptured suture, ileus, and hospital stays. In case of secondary outcome, anastomotic leak and hospital stays were considered statistically significant, with the anastomotic leak with a p-value of less than 0.05, which is 0.0447, and hospital stays with the p-value of 0.02, which were both statistically significant. In case of long stitches, there were 4 cases with anastomotic leak, and the hospital stay was shorter in case of short stitch group rather than in comparison to the long stitch group.
Any comments on the results? Is that clear or? Okay, proceed, sir. Finish the discussion, then we'll come back to the critical analysis again.
Discussion. The primary outcome parameter, which was to assess the presence of incisional hernia at a period of 12 months plus or minus 1 month, was not considered to be statistically significant, with a p-value of less than 0.05. And there were studies on cadavers which indicate that the load-bearing capacity of the linea alba in case of re-laparotomy procedures were excluded. That's why the patients who underwent re-laparotomies were excluded from the study. And the accuracy of detection for incisional hernia was just done for a period of 1 year or 13 to 14 months. And there is a study which was conducted by Sahin et al. And others, which stated that with the follow-up of 3 to 5 years post-operatively, the rate of incisional hernia can increase up to 60%.
Wait. There are some questions for you. One is, there's a question, how would abdominal closure affect anastomotic leak?
In this article, ma'am, they have done a protocol as retrospective analysis. That time, they have considered anastomotic leak as a risk factor for development of seroma and hematoma, which can develop into an incisional hernia.
So it is vice versa.
Vice versa. They have done a retrospective analysis. They have published the case report in 2020, but in March 2015 and April 2016, they have assessed for the secondary outcomes. So in anastomotically, they were suspecting a SSI, which could lead to an increased risk factor for incisional hernia.
The presentation looked like the reverse. Okay. Sorry for that confusion. Maybe she has presented in that way.
No, I think the Kalaibani.
The author has made such good article like that. Yeah, tell me that, Ravi.
I think this is something called post hoc analysis, where you should not, post hoc analysis. If you resort to that, generally that means the quality of paper is not good. If you try to bring a subgroup analysis which you have not actually spoken about before, right? Or if you can't prove your original hypothesis or disprove the original hypothesis, then you bring roundabout ways of saying the same thing, then that kind of analysis is not considered to be favorable in terms of that paper.
Yes. Other postgraduates? Anyone could answer that? What is post hoc analysis? Dinisha? Zaba, you are able to tell that?
Ma'am, in this article, ma'am, they have contradicted their own statement, ma'am. Initially, they were just analyzing their primary outcome, which was incisional hernia, and then they retrospectively went back to analyze the secondary outcome. Like, for example, they considered anastomotic leak to be a cause for incisional hernia.
That is post hoc analysis. There's one question. Loss. Okay. Dr. Ravi, Dr. Ramkrishna wants you to. Anyway.
Dr. Ramkrishna?
Hello.
Yeah, Dr. Ramkrishna. Sir, please tell me, sir.
No, I lost voice, madam. Whether everybody could hear or only I could not.
No, all of us could hear, sir.
Because Dr. Ravi Shankar, what he said, I didn't hear.
No,
somehow I lost it. I wanted to ask the presenter. In this study analysis, they have mentioned something about per protocol analysis. What is per protocol analysis? Have you observed that?
Yes, sir. In the trial design, they have mentioned about the trial protocol, sir. In the trial. Sir?
Hello, again.
Per protocol analysis.
What do you understand by per protocol analysis?
In per protocol analysis, sir, it is a comparison of treatment groups that includes only those patients who completed the treatment which was originally allocated to them.
Yes, the diagram. Consult flow diagram.
Consult. Show that diagram, no? The flow chart. Yes. Sir, Ramkrishna, sir, it's there.
Go back.
This is the one, sir.
Slide is not. Yeah. Consult flow chart.
Yeah. It's visible, sir.
No. This one.
It's visible, sir. Yes.
Yeah. Now, if you have used per protocol analysis, you said those who have completed the trial period, only those patients are considered. Here, in the first group, out of 215, they have taken 210. And the allocation, they have told 16 patients underwent laparotomy, 5 patients died, 9 patients withdrew consent. That means they are excluded from the study. Another 5 patients were lost to study. So how many patients were left for the analysis in the end?
210 were included in the short stitch groups.
How?
5 patients were lost to follow up.
Okay, 215, 5 were lost, so 210. What about this?
Sir, we cannot hear you, sir.
Withdrew consent. How are they available for the analysis at the end of 1 year?
So we didn't hear you in between. We're not able to hear you. Can you repeat the question? Okay, we're not able to hear. Can you please?
No. What he said was.
No, the problem is, madam, they have mentioned they have used per protocol analysis. Actually, they have not used it properly. If they were to use per protocol analysis properly, the first group should have excluded these patients, and they are left with only 180 patients in the first group and 163 patients in the second group. Because here 47 patients were gone, 28 relaparotomy because they are not available for the analysis. 10 patients died, 3 patients withdrew, and 6 were lost for follow-up. These patients were not available for analysis at the end of the study. They have excluded only 6 and they have made 210 minus 6 as 204. This is not correct. This is not acceptable. They should have deducted these patients also, 28 plus 10 plus 3, that is for 38, 41 plus 6. 47 patients they should have deducted in 210, and they are left with some 163 patients or something.
This is for others to understand, sir. Let them understand what is per protocol analysis. Per protocol analysis includes only those patients who complied with the trial protocol can be used to supplement the intention to treat analysis. This is all those people who comply to it and they continue to the end of the study, then that is per protocol analysis. Is that what you are trying to say, sir? But they have not followed it.
Yes, madam. They have neither used intention to treat protocol nor per protocol. This is not acceptable. This is one thing. And somewhere there they have mentioned KM plot was used to depict the cumulative incidence. But in the article, I did not find KM plot at all. There is no.
That is another weakness of this article, sir. For the understanding of the audience, there are 2 types of considerations for statistical analysis of any randomized controlled trials. One is the intention to treat, and second is the per protocol analysis. Intention to treat will be when all of them comply to it and they were there till the end of the study. But if some people get lost in between, then this analysis of per protocol analysis will be taken into consideration. Sir, Ramakrishna sir, correct me if I'm not.
Slightly different, madam. In intention to treat protocol, the denominator will be those patients who are allocated initially. Here it is 215 and 210. Only these numbers should be used, irrespective of how many were lost, how many died, how many not, how many withdrew. All these things will not be considered. You have to use 210 as the denominator. If there are 10 recurrence, 10 by 210, irrespective of the patients who were withdrawn or did not complete the trial. This is intention to treat protocol. If it is per protocol, then you should deduct all these numbers and we will be left with here 165 or something I told you, no? Yeah, right. The first group will be having 180 patients, second group will be having 163. These forms the denominator. If there are 10 recurrence, then it becomes 10 by 163. So if you use that type of analysis, that is per protocol.
So they have used per protocol analysis inadequately.
Yeah.
Inappropriately.
Inappropriately. So this is the final conclusion.
So analysis is wrong.
Yes. So this is for the benefit of all. So I hope it is understood what is intention to treat and per protocol analysis. Shall we proceed, sir?
And conclusion she has written.
Conclusion. Come to conclusion, sir.
Okay.
Yes. And one more thing, if you notice in the discussion, most of the time we should compare with other studies and what is their result and this result most of the time will be compared, which has again not been done in this study.
Yes.
Yes. Okay. Conclusion.
They have concluded that the occurrence of incisional hernia was similar in both the techniques. That is, there were 4 cases in case of short stitch technique and 4 cases in 7 out of the 7 cases, 4 cases were operated in case of long stitch technique. So the occurrence of hernial repair was same in both the techniques, hence making the p-value statistically insignificant. And in case of the secondary outcomes, the quality of life was compared, out of which two parameters, which is anastomotic leak and the hospital stay, was considered to be statistically significant. But in conclusion, they have not compared their study with any other study to compare the rate of incisional hernia and as well as the quality of life in the patients.
See, I think Ziba, the other mistake you made is the quality anastomotic leak is not a parameter for quality of life. Quality of life, they have said it is the 5 factors, which is, I think I think they have detailed that. So quality of life is different compared to anastomotic leak and seroma and wound infection and all those things. They may affect it, no doubt, but quality of life is the analysis different. It's not just about anastomotic leak. It is how you are able to carry on your normal activities. Was there pain? And all these things. There are a lot of. I think there are totally about 9 or 10 factors, which will which will comprise of the quality of life analysis. But one of them might be wound infection, or because it may affect it may cause pain, and it may affect your day-to-day activities, no doubt.
No, sir, I think it is wrong to attribute better quality of life to one of these techniques.
Correct. That's what. Yeah.
Because the cases are different. Some of them may be malignancy. Some of them may be having anastomotic leak because of infection and all, wound discence, all those problems. So the quality of life will be affected by those factors
so many other
rather
things,
than this technique. So
alone.
If one group of patients does well in quality of life, it is wrong to attribute that better quality of life because of this technique. Because there are a lot of
other factors
factors which they have mentioned in one of these groups, these comorbidities. That table number 1, they have mentioned so many comorbidities and different types of complications they had. Some of them had renal failure, some of them this malignancies, all those things. So it is difficult to say it is because of the technique. That is one thing. And secondly, what conclusion she has mentioned, I think conclusion you have drawn. Authors have never given any conclusion in this article. Actually, with a good study at the end of the article, they should have given what are the conclusions of the author. It is not mentioned at all in this article. Only the abstract shows some conclusion. Here in the main study, they have not given any conclusion in this. These conclusions we have to draw.
She has drawn from this, yes.
Actually,
she has given. Authors have not given any conclusions in this. Actually, it is not appropriate.
Ramakrishna, I think this article would have found it difficult to be published in IJS. I don't know how
BJS. Exactly, BJS with a high impact factor.
Oh, they have.
Isn't it?
Because it is sponsored, madam. It is sponsored one, they get it.
Go to the next comments, Zaba. Go to the comments. Where are the other pages? Where are the critical analysis point?
Critical appraisal.
Yeah. Yeah. Other pages? Go to the next slide. Have you put down the questions?
Yes.
Yeah. Okay, let us critically analyze properly. There is one question from Dr. Priyanka. Same study is also published in 2021, the hernia journal. Oh, okay. This is comment from Dr. Priyanka. This amounts to plagiarism, sir. What do you call it?
No. Yeah, I don't know whether you can call it plagiarism. They might have published under different heading. I think it is. You can same study. You can concentrate on 2 different aspects and publish in 2 different papers. For example,
is that accepted? Same material, material being used.
You can use the same material. For example, you can publish only the quality of life indexes in a certain journal, where you are only concentrating on quality of life between the 2 groups. And you can now in this surgical journal, you can compare the incidence of incisional hernia, for example. So you can do that same with same. For example, sometimes you publish an article as a study and then that study becomes part of a very large group of, a multi-center trial. So, the same data can be used, but it has to be made clear that you are using the same data.
Thank you, Dr. Ravi. Now, I want other PGs who are there in this group to kindly give your comment on these points. Is the study question relevant? Anyone? Renisha?
Don't you like her? All the questions are directed.
I know. No, she wants that to shows interest in answering. Anyone else? Who else? Prakriti? Okay. No one else is there. Yeah, Zeba, you answer. Is the study question relevant? So what was the study question?
The study question was in this article whether it was beneficial to use a short stitch technique in comparison to a long stitch technique to reduce the risk of incisional hernia.
Is this a relevant question?
It's a relevant question.
So the entire basis for any article is whether that research question was relevant, so that the same thing which is literature is existing on that, whether this can add to that existing literature, or whether it can be expanded or extended to another set of population and it can be carried out on other patients. That will be the intention of any research question. So that way we found that this question was relevant, right? So the existing literature is that 1 centimeter wide and 1 centimeter distance sutures is accepted in the literature. So in comparison, whether this is better or not. Okay. Next question, please.
The study adds a shorter stitch technique, ma'am, but it is being performed in regular practice also by some surgeons. So I don't think that the study is adding anything new.
I think what Dr. Ramakrishna said about comparing a very heterogeneous group of patients and in an extremely large number of surgeons with the best will in the world, the techniques cannot be comparable. Some people may be in the lower end of the what do you call this learning curve, and others may be in the upper end of the learning curve. So it becomes very difficult, and you can't. You obviously know that patients with pancreatic cancer or patients with renal failure or very uncontrolled diabetes, they are likely to develop maybe infection, incisional hernia, and all those things more than the other group. So I think it's very difficult to, and again, the study period is only 1 year. So the hypothesis itself is wrong. You can't do a study when they themselves know that the incidence of incisional hernia increases after 1 year. So to study only for a year again shows lack of insight into doing a study like this.
All this because it is sponsored study.
Correct. Correct.
So there is no conclusion, there is no clear message in this study.
No, sir. I think, see, what they have done, they have given one study when they're calculating the sample size. And it says the incidence of incisional hernia is very high. And in this study, they say it is very low. So they are trying to push that particular suture material, saying that if you use this, whether it is long stitch or short stitch, you will have very low incidence of incisional hernia. This is the message they want to push. This is definitely biased by the sutures producing company.
Yes. I hope all the PGs who are there are benefited from what Dr. Ramakrishna is contributing. There's another question from Priyanka. Dr. Priyanka, can a study be published multiple times just with subtle changes in title? Dr. Ravi, Dr. Ramakrishna, sir?
So as I told you, I think you can concentrate on different facets. The same study group, if you studied them for whatever, and then concentrate on 3 different or 2 different aspects and publish in different tests. I don't think it is wrong, but you have to state that this study, this has already been published. You should mention that, I think. Ramakrishna?
As
Sir,
far as I have read, they cannot use the same data for different analysis. I don't know if it is being accepted. As far as what we read in the biomedical exams, which we all prepared for, it's very clearly it is said that we cannot use. Sir Ramakrishna, sir, any comment from you?
No, I didn't hear, madam. I lost voice in between.
So the question is, same data with subtle changes, can the same data be used with different publications?
No, same data means if the study research question is different, then we can use the same data. Otherwise, we should not. Sometimes what happens, the one study gives only 1 year follow-up, and this study gives the same methodology, same protocol, but the follow-up period will be 10 years. Then it is acceptable because we have got better data there, strong data. That is acceptable. But if everything is same, this study also gives only 1 year data, then this is not acceptable.
I hope that answer is very clear. We move on to the next question.
Siddesh sir has raised his hand.
Sir, Siddesh sir? Siddesh sir?
He went off.
Okay, I'm not seeing anything. Okay. We'll move on to the next question. What is the type of research question asked? Zeba?
Ma'am, it's an epidemiological research question, ma'am. It is a observational group of research study, ma'am. They are observing a short stitch with a long stitch, and they are comparing the outcomes of the results.
No, ma'am, this is not observational study. This is the interventional study. Because they are intervening with the system. They are giving one type of intervention to one group of patient, another type of intervention to another group. RCT cannot be considered as a observatory study. It is always intervention.
Intervention, yeah.
See to the next. Was the study designed? Come on, Zeba. Go ahead.
The study design was per protocol analysis, ma'am. As sir said, they did not follow the proper study design for the article, ma'am. Like they could have excluded the patients which died and who lost to follow-up, which would reduce the group to 164 patients in the long stitch and the short stitch. So the study design was not appropriate for the question.
See, no. You are confused. What you said is analysis. What is this question is study design. Design is appropriate for that research question. Randomized control trial, that is the study design. It is appropriate. Problem is with the analysis of the data. That is wrong. But the design is appropriate for the study question.
The randomized control.
Only flaw in the design is that the change of protocol in between. I think that is wrong.
Yeah, that is wrong. That is a weakness.
Proceed to the next question.
Does the study test the stated hypothesis? The hypothesis was if it was beneficial to use a short stitch technique, ma'am. But the rate of incisional hernia were similar in both the studies, so it doesn't test the stated hypothesis. Does the data justify the conclusions?
No. The previous question, whether the study tested the stated hypothesis.
It does.
It was testing the stated hypothesis, ma'am. It was testing the rate of incisional hernia, but in comparison, both of them had the similar hernia.
That is not
conclusion.
Yes.
It was
conclusion. What you are telling is conclusion. See, the test is it is correct actually. Means the study test the stated hypothesis. They started with a research question. They have designed a proper study to test that, and the study test the stated hypothesis correctly. The conclusion may be either positive or negative. They start with saying one is superior to other. In the end, they may say both are equal or one the other way around also. The first one is inferior to second. That is immaterial. Whatever data says, that way they have to conclude. But this question, we have to answer yes. The study test the stated hypothesis. Yes, it has tested. It is correct.
Thank you, sir. Next question.
Does the data justify the conclusions? The data which was given in this article was like the rate of hernia repair rates were similar in both the groups. Like 4 cases were operated in both the short stitch as well as the long stitch.
Okay. But conclusion, they have not mentioned only, no conclusion.
They have not concluded the article. They have not concluded the article. They have not come out to a proper result and they have not compared their article with any other article to conclude their data.
They have concluded the article, but they have not made any conclusions.
They have no, in the abstract they have mentioned the conclusion, sir. In the abstract, they have mentioned conclusion as the 1 year incisional hernia development is relatively low and statistically not different between these two groups. That is the conclusion they have given in the abstract. But in the main article, they have not given any conclusion.
But in the main article, also conclusion has to be given, isn't it, sir?
Yeah, it has to be repeated in a little more detail. And with that data, whatever they have given, I think that conclusion is acceptable. The problem is the type of analysis of the data is questionable, but whatever they have given, the conclusion based on that data, it is acceptable.
Dr. Rajesh, any question from you?
No, I just had a comment.
Yes.
I think the postgraduate needs to be told that you don't have to prove what is there. It's already stated.
Yes.
Right? Yes. Like Dr. Ramakrishna correctly said, for that question, does the study test the stated hypothesis? The answer has got to be yes. And that has to be stressed, I think.
Yes.
Because the postgraduate is under the belief that, you have to prove that. There is no need.
Understanding, Zephyr, you don't have to defend the article.
Yes.
That is what is critical analysis. And in the end of this analysis, you should draw a conclusion whether this article is genuine, whether I can follow this technique which is mentioned, whether that will be of any benefit if I do, whether it can extend on to your patients. That is the end result of any article that has to be done. So it is a learning process for you, how you have to write an article or how you have to do a study. Right? Any other comments? Sir, Satish sir? Shivram sir, anyone?
Yeah, good evening. Thank you, Kalevani, you have done a good program. I am just traveling in the train to Chennai to attend a program tomorrow there.
Okay,
but
sir.
still, it was so interesting, I thought I will just join in. Getting educated by excellent experts, Ramakrishna with such wonderful comments.
Yes, sir.
Thank you, Dr.
He's doing a better job than filtering these such articles. Yeah. Can you hear me? Yes.
Yes, sir. Very much.
Okay. So nice. And I should congratulate the office bearers for doing such a wonderful programs. Everything is going on so smoothly this year. And particularly this paper, what is being studied, I think it is nothing wrong in taking up this way of learning whenever we take up. And my question would be, in general, at the end of this paper, would like to ask the experts, especially those who are practicing advanced hernia procedures, what do they do for abdominal closures, whether they take shorter bites or they have the conventional way of closure. So that is one question, just as a process of learning, if there is anybody who can chip in and clarify for the sake of postgraduates.
Sir,
thank you.
Sir, Ravi Shankar.
Thank you, sir. Thank you, sir.
Kalevani.
Dr. Ravi, please.
See, I am talking from the experience of having worked in the intestinal failure unit in Manchester, where we would operate on laparotomies and long-standing fistulas and complicated Crohn's and malignancies and things like that. I think, I think in general, using the Jenkins rule and using a good stitch, which is delayed absorbable stitch, so far proved is the polydaxanon or this one, what is commonly for PDS. Okay, so PDS is currently the best stitch that is advocated, 1 centimeter across, 1 centimeter apart, and the length of the suture should be between 3.5 to 5.5 times the length of the incision. So that is the current rule. And I don't think as of now we have any proof to say the short stitch is any better than the long stitch. So I think we should continue to use that. But what I would say is in terms of, for example, using relaparotomies, burst abdomen and things like that, what we have seen is Professor Leslie Hughes from Cardiff, his technique of near far sutures, interrupted near far sutures. You don't use a continuous suture, you use near far. So you can either use either 4 loops or 8 loops, and near far, or near far, near far, near far, near far. So either 4 loops or 8 loops, interrupted sutures in patients with complicated abdomens and in patients who have burst abdomen and things like that. Don't use continuous sutures, but use interrupted sutures. That is what we used to follow in Manchester. And I follow the same thing here.
Thank you for that input. It has really cleared many doubts, I suppose. Now, there is one question. The outcome table presented, which included seroma and hematoma anastomotic leak, is not there in this article. It's given in the hernia journal article. Is this a combination of the 2 articles? Zeba, what's your answer on this?
It's not a combination of the 2 articles. In this article only, they have mentioned about 2 references, which is the 15th and the 16th references, where they have done a protocol analysis of how they have gone about the study design. That time they have analyzed the secondary outcomes of the article, which is anastomotic leak and hospital stay.
But the thing is, they're not mentioned in the conclusion, and so all this confusion, right?
Yes.
Okay. Any other question from the audience?
Yeah, Kalevani,
sir?
Anybody has the experience of using Monomax in this group?
I don't have, sir. Anyone else? Dr. Ravi? Dr. Siddesh, sir?
Oh, okay. Zaiba, you must have done some collateral study. What is the difference between Monomax, which they have used in this article, and PDS?
In this article, they have not compared the Monomax with any other.
No. Have you read? And what is the difference between PDS and Monomax? So, that's the first question.
In case of, there was an article which was done in the year 2014. Where
yes, Zaiba, please tell what is the difference between PDS and this?
This is a non-absorbable suture material.
Delayed
absorbable suture material with a tensile strength of 90%. So in Monomax, but PDS is a absorbable suture material with a tensile strength of 45 to 50%.
No, within how many days?
Days.
Monomax is generally, it is absorbed with in a period of 90 to 60 days. Sir, but
100 days, Zeba. Monomax is 100 days.
100 days with 50% of basic strength, and PDS is it is absorbed in days of 100 to 120 days with a tensile strength of 90%.
Zaiba, I have a comment here. We are not looking at absorption of the suture, We look at the tensile loss of the tensile strength after a particular period. You understand? See, if the tensile strength of the suture material is X, if it gets reduced by 50% of its original tensile strength, the duration of time which is taken for that reduction to 50% is the significant end point. So that varies that is why the early absorbable sutures like CAD-CAD is hardly few days of that is the strength going down by 50%. Whereas it is up to couple of weeks in case of Vicryl, but it is much longer in case of PDS or polydioxanone. So I don't know about this particular material which you're mentioning. So it's a delayed absorbable should be much longer.
Yeah.
And non-absorbable is one which the tensile strength remains almost the same in middle of the time. So that is what you should look at. Thank you. It is not absorbable time for absorption.
Sir, another
Yeah. Ramkrishna, please.
Another difference they have given is great elasticity. It is
Elasticity,
highly
yes.
elastic compared to PDS. That is the difference between these two, PDS and this
No,
suture material.
maybe
And
have they done any in vitro studies to prove that the the whole thing is the suture material should support the incision wound for a longer period enough for them till the time mature collagen gets into adequate strength to support the wound. So that is the ultimate purpose of suture. So that's what I was trying to say.
in that case, why should not use this polypropylene or nylon, sir?
Absolutely,
Polyamide.
absolutely. See, only problem with polypropylene is I am still using that as the most widely used. It is cheaper. Only problem which has been told is at the end of the knots are bulky. If there is an organism which can harbor stitch sinus and pain at the site of knots, these are the only two problems which have been found to be associated with non-absorbable sutures compared to delayed absorbable. And I think I agree that if that is managed well, the knots and contamination part is managed well. So I think non-absorbed should be equally good as these delay absorbable. And we
pain is also more with non-absorbable.
Still don't know. Is it in particular situations where tissue healing is little delayed because of other comorbidities which you mentioned earlier? So this.
But the author mentions that it has a very high elasticity, that is 90% elongation versus 45 to 50% for polydioxanone based sutures, and an ultra long term absorption, that is 100 days percent basic strength retention versus 35 to 42 days. That is what the author claims.
Yes.
Yes, sir. Yes, some disturbance. Yes, sir.
Yeah, Kalavani, can you hear me still?
Yes, sir. Yes.
Elasticity, I am looking at one aspect of it. The onset of invasion of type 1 collagen occurs little later after the acute inflammatory process comes down in the wound. So in a case where the elasticity is more, the sutures produce less of strangulation effect on tissues which are approximated in between the suture line. So the amount of inflammation which is setting may be little less. So that may be the proper property which they are trying to push. Unless this is proven in both in vitro and in vivo, I don't think that should be taken just blindly. That elasticity thing. Okay.
Yes.
So
Yes,
that's
sir.
what they are looking. Thank you.
Thank you, sir. Thank you so much for your input, sir. I think we should thank Zeba for her good presentation. And thank you, Zeba, and thanks to all the contributors, Dr. Ramkrishna, Dr. Ravi, Dr. Siddesh, sir, and Dr. Shivram. Thank you so much, and also all the other audience, Priyanka, Dr. Naz, Dr. Dayanand Nulisa, for all your inputs. Thank you so much. Over to Chandra, Dr. Chandra.
Yes, sir. Yes, madam. We'll conclude.
Yes.
Yeah. Behalf of KCSI, I must thank Dr. Zaiba for her excellent presentation. And also, I congratulate Dr. Kalaimani Madam for moderating the whole session. And I thank all the members who are present till now and participated in the excellent discussion and sharing their knowledge. And thank you, one and all. Thank you very much.
Thank you, Dr. Rajesh. Thank you. Thank you, everyone. Thanks, Zeba. Take care.
Thank you.
Thank you. Okay. Thank you. Bye. Shall I leave now?
Good night. Good night.
Good night. Good night, all.
Good night.
Good night.